Hello, this is Cameron Sabat from Cutting to the Case, and today we're joined by Dr. Seth S. Leopold, professor of orthopedic surgery at the University of Washington and editor-in-chief of Clinical Orthopaedics and Related Research. He earned his BA in biology from Dartmouth College, then his MD with honors in research from Cornell. He trained at the University of Chicago in orthopedic surgery and completed a fellowship in adult hip and knee reconstruction. For more than 2 decades, he operated on patients with hip and knee arthritis and complex joint replacements. And in recent years, he's refocused his career on purely editorial leadership, research integrity, and patient-centered consultation. In addition to leading CORR, he created Correlations, a resource that distills musculoskeletal research into clear and clinically relevant insights. Outside of medicine, he's an avid sea kayaker, aerobatic pilot, former boxer, and jazz piano player. He's been married to his high school sweetheart for decades, and they have two college-age daughters. Thank you so much for joining us today.
Nice to be here. Thank you. The girls
Absolutely.
are in college, though. If they heard that, they'd be unhappy.
Oh, college. Wow. Okay.
Yeah,
Fantastic.
time
Yes.
marches on.
Of course. So, I wanted to go back to all the way to the beginning. What first drew you to orthopedic surgery, and how did your training experiences at Cornell, University of Chicago, and Rush influence your career path?
Well, that is going back a ways. It's hard to remember exactly what triggered which decisions, but what I think all of those places had in common for me were really great mentors. And I would say the same held true for after I finished my formal training and when I went into the Army as a surgeon and as a faculty member at one of their teaching programs. And the same has been true for me at the University of Washington, where I've been a faculty member for a while. There's always somebody, who you can find in your environment who's better than you are at something you'd like to get better at. So I didn't really pick orthopedics or joint replacement surgery initially because I had a particular interest in them. It turns out that in both of those cases, there was, somebody whose path I crossed who I thought really was doing neat stuff and, was also a neat person. And it made me want to be a little bit more like that person. And so that's sort of how I got drawn into those things.
Mhm.
And again, the same was really true during my time in the Army and here as a faculty member at the University of Washington. Even as a senior faculty member, there's always somebody who's doing something better. So, my best suggestion for anybody who might be listening to a podcast like this is, especially at the beginning, is really scour your environment for good mentorship and find it and value it and grow from it and thank the people who are mentoring you. And we can go further into that if you want. The trick is, of course, figuring out who that person or who those people might be. Not everybody who you might want to be your mentor is going to want to be a mentor or your mentor. I've had both of those things happen, and you got to make sure you're barking up the right trees. But that's really what it's been for me at every station that I've been at. Is there's always somebody who is doing stuff really well, and I've wanted to be around them and be more like them.
Absolutely. And it's really all about mentorship and looking up to people as exemplars of what you want to be in your career. Absolutely. And really, also, you've introduced new features to your journal moving forward, such as Take Five. And I was wondering if you were able to, previously I mentioned correlations, that I meant to say Take Five there. Um, how do you think that kind of moving forward, publishing should evolve to better serve surgeons and trainees in the coming years?
Yeah, so we tried to enrich core by having it be a lot more than just publishing the best scientific articles we can get our hands on. That's sort of where it began. But when I started, I looked around at what I thought were the best general interest journals of all professions, to go outside of surgery, to look at JAMA, the New England Journal of Medicine, but even to go outside of medicine and look at Nature and Science. And those are really big tent kinds of publications. They if you're going to be reading Nature or Science, you might be a botanist or a particle physicist. You might have very little in common with some of the other readers, but yet you're reading the same journal. How do they pull that off?
Mhm.
So that was sort of what I was curious about when I started. One of the things I was curious about when I started at CORR was to figure out how to, to sort of broaden a journal so that it becomes, so that every piece of content in it, or as much of it as possible, is interesting to as many readers as possible. So that's where the columns and the commentaries and the interviews and the editorial features, we think that adds to that. But to your, I think your question was even broader than how to make a journal interesting. I think you said something like how can you make journals, or how should journals evolve to better serve, did you say surgeons and trainees, I think you said. Um, am I remembering the question exactly right? Was that what you were after?
Yes,
Yeah.
yes.
Yeah. So, I mean, I think that we have to realize that there are sort of boundaries around what I think journals can do well.
Mhm.
So I think maybe the conversation has to go beyond what journals can do, and rather think about how we disseminate information, in general, and it may not always be a journal. But I would say in general, the most important thing probably for our profession is we need better approaches to meeting the needs of surgeons who practice outside of university or academic settings.
Mhm.
That's about 85% of orthopedic surgeons.
Mhm.
And I think journals serve that audience very poorly for reasons that we can talk about, if you want to. And then, the other half of your question was about learners. And there as well, I don't think journals do a great job, because the needs of somebody who's a medical student curious about musculoskeletal problems and the needs of a orthopedic intern or a second year resident are different than a chief resident, are different than a fellow, um, and are very different than the lion's share of the readership of, let's say, a general interest orthopedic journal.
Mhm.
And those kind of academic journals, CORR, JBJS, are very effective at what they do well, but they've had a very inconsistent record when they've tried to do other things. If you, maybe this predated you, happened before you were born or when you were younger, but at one point, Kentucky Fried Chicken thought they would start to make pizza and broaden their menu. And they didn't do a great job with pizza, but they do all right with chicken. And so it's part of it is figuring out what are you really good at and what are you really tooled up to do, and make sure you're not a chicken restaurant trying to make pizza. It may be that the best tools for learners or for surgeons outside of academia may not come from journals, but may be other kinds of startups or other sources. But I think journals can and ought to be really good at what they're supposed to be doing, or at least what their historic remit has been. And I think that is to be let's say the trusted intermediary, if you like,
Mhm.
between people who are discovering new things or synthesizing those discoveries and those who've got a particular reason to be interested in those discoveries.
Mhm.
And so, as much as I've tried to make CORR more interesting and more approachable to more readers, I'm not sure that I really succeeded in broadening our audience by very much. We've got metrics that show that I've deepened it, but I don't really think that I've broadened it by very much. And we can talk about, what I mean by that. But I don't think I've really made much of a dent in making it appealing to, let's say, the surgeon in private practice, for whom, an academic journal doesn't serve very well, for, again, reasons we can talk about if you want to. But not everybody who practices orthopedic surgery is going to find CORR or any journal for that matter, exactly what he or she needs to do a better job in the office or the operating room that day. That may be other tools that haven't yet been developed, or we've took a stab at them, or others have. But I think there's a lot of room to run there for people who want to do a startup.
Could you maybe provide some examples for our audience of what is missing in that piece?
Yeah, yeah, sure. And you mentioned a publication called Correlations that we were doing a couple of years ago that I think got close to it, and we didn't sustain the funding on it. We couldn't sustain the funding on it, but I think that was maybe a little closer. We did a lot of research to try to figure out why it was that most people outside of university practices don't find journals helpful. And the messages we got were were really fascinating and fun to learn because it kind of pointed us in a direction we hadn't taken and that nobody had taken, has taken. And that's that, the people who are in community practices, private practices, outside of university settings, they have a good idea of what they're about. They know what they want to do. They know how to do what they do. They know what they do well. They know what they don't want to do more of. They know what the boundaries are, what they want to send to somebody else who's, more involved with big, long cases. It's often a high turnover, high throughput kind of operation, seeing a lot of patients and taking really good care of people at scale.
Mhm.
Um, these are also small businesses, sometimes medium-sized businesses. And that, takes up a good bit of folks' attention who practice in those settings, how to be a good steward of their resources, take good care of their staff and their teams and their partners. So there are a whole sort of themes there that don't get picked up very much in journals at all.
Mhm.
And the pace of journals is wrong. They're really deep, right? You pick up an article in an orthopedic journal, it's a pretty detailed experience, right? It goes on for pages. The main message may or may not be immediately applicable. It may be building on something else. So you're investing a good bit of time to understand a paper, and that may not be immediately actionable to you.
Mhm.
Um, if somebody in a community practice, non-academic practice, in a high throughput practice is going to spend time reading, he or she is likely doing that for a particular end. Is there something that can help me get through clinic faster, more efficiently, take better care of people in the clinic today, right now, not in 2 years, not if it gets validated by 5 more randomized trials. Um, and the same thing for surgery. They already know how to do the operations that they do. And so if they're going to spend time reading, it's got to be something that's immediately practical.
Mhm.
And, the way that they have to slice their time because there's so many demands on the time of somebody in that setting, um, any content has got to be very, very quickly delivered. Like, we found that if it couldn't be sort of read on the phone while you're online at the grocery store or between the time you walk out of the hospital and before you get to the side door of your vehicle, it was
Mhm.
too long. It was too long. So they were really looking for immediately actionable, trustworthy, practical clinical messages, as well as those same adjectives, and then fill in business messages. How to run a more effective, more efficient practice. And journals just don't deliver that stuff. It's just not what they've ever done. Journals engage in sort of the conventional and time-tested approach to science, which is almost always incremental.
Mhm.
It builds on what's there before. You've really got to make your case in a very systematic way, if you like. And that takes time and patience and effort, and it's not going to be done usually with a single paper. It's very rare that one paper changes how everybody thinks about something. I mean, it's almost never happens. So they're very different kinds of audiences. The audience of people who are doing these discoveries, interested in these discoveries, wanting to make the next discovery, and a very separate audience of people who are in high throughput practices where they know sort of what their bread and butter is. And if they're going to be reading something about science or discovery, it's got to be much faster than that.
Engagement really seems to be a priority here. Engagement with broader and broader circles. I am also curious that, there's a new kind of um, momentum in the field toward values-based decisions for patients and emphasizing like helping patients make those value-based decisions about joint replacement. How do you approach those kinds of conversations, or how did you approach them when you were in practice? And as editor-in-chief of CORR, how do you see the journal's role in shaping the direction of the field toward kind of implementing um, changes in care delivery? For instance, value-based care, how these private practice surgeons actually perform their practices.
Yeah, that's a big question. I'll unpack it as best I can. First of all, I wish that the premise of the question were true, which is that, I wish that there was some sort of wave or momentum towards listening better to patients and trying to understand what it is exactly that they seek with each touch, with each encounter that they have with us. I haven't observed that trend. Um, the trends that I see, are sometimes in quite a different direction, right? I see a trend towards incentivizing throughput, scaling operations, including practices, trying to tool a clinic so as to get the most cases possible, shading indications so as to be able to do more surgery because most of us are paid by the piece. For what it's worth, I am still in practice. I'm no longer operating,
Mhm.
so this isn't hypothetical to me. I still sit down with patients and talk with them, um, but yeah, no, I think I wish there were such a trend towards listening better to what patients seek. I think, Dr. Sabat, I think that what you said is the most important question there is. I think it's our deepest professional obligation. The one of the best questions that a doctor can ask a patient when you first sit down with him or her is, how can I help? What can I do for you today? Right? And it really is about the you. It really is about the other person. And then to sit and listen, to let that person spend a little bit of time telling us what it is that they're seeking. I think we fear open-ended questions sometimes in the office setting. We're afraid that if we ask open-ended questions or too many open-ended questions, the patients are going to talk for a long time, and then we'll be late for the next patient and the patient after that. And we won't be able to get through the clinic roster. And so we may have a tendency to ask whatever the opposite of an open-ended question is, sort of short answer questions or closed-ended questions. Or we ask these open-ended questions and then we get fearful when they start to answer them and we might cut people off when they're speaking. I think it's actually time well spent to begin with a couple of open-ended questions because you actually get where you're going a little bit faster. I think if you do that, you have a better idea of why the person is there in the first place rather than what you guess the person is there for, which can take you down paths that themselves can be time consuming.
Mhm.
But no, I think listening better. I think that our deepest obligation is to take care of that person in front of us, and the only way to do that is to figure out how to become more tuned in, more empathic, more caring listeners to try to apprehend that individual's values. What is that person trying to get done? What's their tolerance for risk? Um, what's their level of distress with the symptoms? Is all of the distress from the musculoskeletal symptom that we might be treating, or is there something else that's feeding that distress, like anxiety or depression or a fear that they may not be able to go back to work, or they don't want to go back to work, or they are afraid that somebody has gotten them all these pain medicines and that now nobody's going to keep prescribing them. What is the deepest fear that's animating that conversation? What are the deep motivators that are animating those conversations? Are they missing a cherished activity that they want to get back to? So we've got to listen. We've got to be open to that. And that takes time and care and empathy. And that's not easy, right? It's not necessarily everybody's first strength. Some of us went into surgery because we're really good with our hands, or we really like to solve focused, specific problems. This is a different activity to that.
And when you dive into these interactions with just what you assume to be true, I can only imagine that heuristics can lead to bias. And you've studied bias extensively, especially in peer review as well. So this kind of seeps into every crevice of orthopedics, really the same philosophy of listening better. I was wondering what blind spots or biases most concern you in orthopedic research today.
Well, so yeah, we were talking just there about what happens in the office, and we do carry biases and heuristics into those encounters. But this question, I think you're asking me, is a different one. You said orthopedic research. So that's a different activity. I think the most important problem we've got, or blind spot we've got there, is what I would say is the misperception or the misconception that the activity of research is meant to serve the needs of the people doing it rather than serving the needs of those delivering care at the point of care or the people receiving that care. And this may sound weird. What do I mean by people doing research are feeling that this research is meant to benefit them? People, I think too many people see research as what they're doing to get the next promotion or what they're doing to get a certain level of recognition from their peers or notoriety in their professional community. And that can sound sort of like an unsupported bit of speculation on my part, but I'm gonna try to substantiate it. That I think that this actually is a problem at large scale. The two biggest issues that I am faced with right now are um, a problem called preprint servers. And I don't know whether you're familiar with what a preprint server is or whether your audience is likely to be, but we can talk about that if you want. Um, and the inappropriate use of AI and large language models. So those are the two maybe best examples, but not the only examples. Those are two things that make it way easier for people to disseminate research,
Mhm.
to get some kind of credit for research, to do more research in less time and get more points for it, whatever those points look like, or however they're being measured, whether it's notoriety or recognition or a promotion or whatever. Um, but they do not make it more, they don't make the work better, more useful, more trustworthy for those who are reading it. In fact, they make it much less trustworthy. And when we lose that trust in the context of orthopedic research, when we're not sure if a claim being made that has been filtered through a large language model is a bit of hallucination, or whether the reference says what the person says, what the human author claims it says, because he or she didn't check all of the references that the large language model generated, and 30% of them are hallucinated.
Mhm.
Um, when we lose that trust, when we put stuff up on preprint servers before it's fully baked, without any sort of peer review so that we can get credit, whatever that credit looks like for having done a project. It turns out it's not a very good project, but now it's out there for any large language model to scour and be considered part of new knowledge. We're taking bricks away from the foundation of trust.
Mhm.
And so, while neither of these things is a bias per se, they're a huge blind spot. The concept behind them is a huge blind spot, and that's that research is meant to serve us rather than we do research to serve other people.
Yes, yes. I mean, really, unfortunately, it's flipping the narrative. I mean, your statement there is flipping the narrative on its head. Um, and yeah, I mean, it's just who is all this work meant to support? I mean, it's oftentimes interesting seeing how anytime you create a new metric, it can be gamified. There are a lot of discussions actually, and I wanted to ask you as well about the gamification of the H index and steps forward from there. I was working with someone from Harvard, Leo Celli, and he's a leading artificial intelligence researcher. And together we're developing this new index called the Community Index. And so we're trying to kind of rethink and reshape the incentives in academic medicine for publication. And I was just, I mean, away from volume and more toward, quality of work. Are there new indices that you've been looking at that have come out that you've kind of preferred, or, as a leading journal editor, do you have any solutions for this?
Yeah, I spend most of my time trying to talk people off the ledge about the idea that impact factor, which is the H index at the journal level, and the H index is the impact factor at the human level, at the level of the individual scientist. They're both, bad metrics for what we are trying to say, right? What you pointed to alludes to something I think people call it a Goodhart's law. When a metric becomes a target, it ceases to be a good metric.
Yes, yes.
Um, and so all of these things are susceptible to that. And so I think, you know, eh, what do I care about an editor of a journal? I'd like to see people reading us, right? I'd like to influence the conversations. The only way we can do that is to know that people are reading us. It's getting harder and harder to know that, because people, websites now, cookies get blocked and all this. So we don't really know to the same degree we did, let's say 5 years ago, what's being read as much as anything else. It's gotten much harder to know that. Meanwhile, there's a proliferation of new metrics like the ones you're alluding to, and misuses of the old ones like H-index and the impact factor, where people assume that a high impact factor, a high H-index is a measure of quality. I don't think that that's has to be true. I don't really chase either of those metrics. I don't chase the H-index as an individual scientist nor impact factor as a journal editor. I think they're misuses. The idea here, I think, for individuals is, if they're doing research, part of that incentive is because they need to get promoted at their university. I think the place where this could be improved are the promotions and tenure committees at universities that could take a more ecumenical view of what a contribution is. Um, None of these, not even the biggest ones, not even the biggest, busiest universities, are factory scale. These are all rooms with people in them, and it is possible to make decisions on basis of quality, rather than on, tonnage. And so I think, the primary responsibility of that falls, as it always has, to universities. Universities can do that better. And the more forward-thinking ones are doing it better. They're willing to look at a person's contributions not as a function of his or her H-index or the number of papers he or she published, both of which are becoming, meaningless, right? Because you can publish anything this minute on a preprint server. You can publish anything tomorrow on a low bar, pay to play, open access journal. There are now over 300 indexed orthopedic journals. The numbers of citations are, not even comparable to what they were 10 years ago because there's so many journals and places where you can get citations from. So we got to think of a more sensible way, and to me, that's, like at our promotions and tenure committee at our university, which is a pretty big university, that committee in our department had, at any given meeting's got 10 people in it. It's, we're looking over 50 faculty members. That's a big department, right? That's a manageable task. You do it once a year, you break it down into 3, 4 meetings. You can give everybody, every candidate, some quality time going over their contributions without looking at those kind of misleading metrics.
So when you say that, I find that very 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 important and very interesting. I was wondering, so for like the Lancet or CORR or alternatively very high impact journals,
Yeah.
it's often a shorthand, and I'm mindful of the time, and I want to this can be the last question as
No,
well.
I've got nowhere to be, Dr.
Oh,
Sabat. I don't know how long your listeners are going to listen, but that's another matter.
yes, absolutely. Um, when 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 someone publishes in CORE or
Yes.
JBS, these are shorthand for excellence. And when there is, such a publications arms race for medical students, or even college students,
Yeah.
even for, select universities, high school students, when someone publishes in Nature, that is a universal marker of success. And when we remove the impact factor, what becomes the substitute for the shorthand, and how do we differentiate junk journals, like you mentioned, those open access journals, from the leading ones without impact factors?
Well, to be clear, not every opening, I wouldn't want to imply that every open access
Yes,
journal
yes,
is junk, but
of
there's
course.
a lot of low bar open access products out there for sure.
Like you're a foot and ankle surgeon and you're assessing spine surgery. Or like,
Mhm.
you're sitting on a med school admissions committee and someone published something in Nature, but you don't know whether Nature's a top journal anymore, and you're assessing biochemical research.
Right. So, I'm not as discouraged about that as you are. I think that if, for starters, my question to people is, what do you read?
Mhm.
Which journals do you read every month? That's the first question. So are you sending your work to journals that you don't read and have never read because you think you could get published there? If you are, who are you serving, right? Because if you're not reading it, who is reading it, right? If you're sending this to some sort of third tier, fourth tier open access product or a crummy journal of some sort because you know you can get your paper published there, you're adding noise to the signal that's out there, but I don't know that you've really improved human health by very much.
Mhm.
Conversely, if I were a scientist, a laboratory scientist, I might read Nature and Science and I might be blissfully ignorant of what their impact factor is.
Mhm.
I read them because I know when I read them, the quality of what I read is good. The work is good. You could take away CORR's impact factor or JBJS's impact factor, and it wouldn't make a dime's worth of difference. If you look at our specialty, the differences among the top 10 orthopedic journals wouldn't be a rounding error um, in, let's say, the second tier of internal medicine journals. All of the orthopedic journals that are in the top 10 have impact factors, clumped in the ballpark of 4 or 5 or something like that.
Mhm.
Maybe 6 on a good year. Um, so you got 10 journals clumped into within a few decimal places of each other. The difference between a second tier and a first tier internal medicine journal, let's say like an Annals of Internal Medicine and a JAMA or a New England Journal, that might be a 4x, not 2/10 of a point.
Mhm.
I mean, so we're talking about stuff that's like a fraction of a citation over 2 years, and that's some kind of metric of quality. That's crazy talk, right? So this year, CORR's impact factor was better than that of JBJS for the first time in the history of either journal that I know of. Who cares? Does that make CORR better than JBJS? Was JBJS better than CORR last year and CORR is better than JBJS this year? Did something change? Nothing's changed. These journals are these journals. Be a discerning reader. If you're sitting on a promotions and tenure committee, give your candidates your time, to care about their work. If you're a scientist and you're not on a promotions and tenure committee, you're trying to decide where to put your work. If you're a med student, work with your mentor and ask him or her, what journals do you read? What journals do your colleagues read? Can we aim for that? Can we design a project that's good enough to get there?
Mhm.
They don't have to know what the impact factor is. Most people talk about this, don't know how the impact factor is calculated, wouldn't know if something went up or down. It's a misperception. There are better ways to think about this, I think.
Absolutely. Yes. Yes. Yeah. Yeah. And the final question, I really do want to be respectful of your time here.
Fine.
Looking ahead, what changes or challenges do you anticipate for orthopedics in the next decade? And what role do you hope that journals and the young surgeons in our audience will play in meeting them?
Uh, well, I think the trends that we've seen aren't going to go away overnight, right? So, um, people are feeling pressure to produce clinically. I think that's not just true out in community and private practice. There are pressures at university practices to turn the crank. And I think that may be the thing that's shaping our profession the most right now is that set of pressures. Um, and when you get out from your residency, you're going to get hired by a group. And that group in part is going to want to know, can you turn the crank like the rest of us? And so you can see where all the incentives are lining up.
Mhm.
If you're in a room with a patient, there's a close call on indications. Which way is that decision likely to resolve given that set of pressures?
Mhm.
Um, so I think when you first get hired out of residency, you have to demonstrate somehow to the people who've hired you that you have a good work ethic, that you're capable of being efficient, that you recognize the values of the group. But I think I love the way you asked the question, which is what can your generation do in the face of this or even to solve it? And I think you have this opportunity. I think everybody has this opportunity, but it seems that people, middle adulthood and later have sort of forgotten it, which is that, once you're not trying to make an impression on a new group, once you're not working for them anymore, but rather are incentivized in the bonus pool or however that's measured so that you're a partner rather than an employee, you're going to be able to cover your own overhead fine. That's not going to be a problem. And even if you were at the bottom of the compensation scale of whatever practice, whether that's university or community or anywhere else, you're still going to be making by any measure a good living, right? There are very few surgeons. I know very few surgeons who stand on the side of the freeway with a sandwich board that says, "We'll do surgery for food." Um, and so the question is, once you cover your overhead, everything you do after that, in a sense, is optional. And so then what you then get to decide is how do you want to balance your time versus your money? And how do you want to make these choices about who are you serving and what are you about? And that's I think your biggest opportunity. I've made some choices on that where I was always busy, but I never felt like I had to be the busiest because I really enjoyed visiting with patients in the office and sort of listening to hear what they were about. And I always wanted to be home for dinner,
Mhm.
if I wasn't taking call. So I never tried to put 5 pounds of flour into a 3 pound sack in the operating room and wind up operating on an elective surgery day till 11 o'clock at night. That wasn't what I wanted to do. I wanted to see my wife and I wanted to see my girls. Um, and so these are all choices, the cross product of time and money is one, so you can spend more time at it or you can make less money, but you probably aren't going to be able to do both. But this has a whole bunch of knock-on effects that go back to the values we talked about at the beginning of the conversation. And I think your generation's capable of making better choices on this than maybe some of the people who are mentoring you now.
Sure, sure. Thank you very much for that inspiring note too to the next generation. I hope they take it to heart. And yeah, thank you so much for joining this podcast. It's really an incredible guest, and the leadership you've shown is just inspiring. So
That's awfully sweet. Thanks, Dr. Sabat. Thanks for having me.
thank you very much. This is Cameron Sabat on Cutting to the Case, signing off.